So osteoarthritis unmasked. Okay, so here are my disclosure. So you know who is paying for that research and what we are doing with the outcome of the research. Here we go. So a little bit of background about what is osteoarthritis. Okay, so most of you understand that osteoarthritis affects knee joint, hip joint, a different type of joint, but it's also affect underlying bones and also skeletal muscles. So it's a very complex disease, okay? Instead of rheumatoid arthritis, where you have only an effect on targeting the joint itself with a lot of inflammation, okay? There's not a lot of inflammation in a way, a lot of pain, very complex to understand the etiology and how it progresses. In terms of progression, there's limited tools available, okay? You can use X-rays, and this is an example in the bottom, so here, so you see what we call the X-rays score, Kellgren-Lawrence scoring, but this is good for only 30% of patients. So you capture about 30% of the patient, and you may have people that not having a lot of pain, not functional at all, and they don't see any sign. If you do X-rays, their knee joint will look almost normal, okay? So that creates a lot of ambiguities about how we study and how can we predict who will progress. But obviously, the end stage of the disease, you are what we call bone on bone. It's a lot of pain. Secondly, there are two types of osteoarthritis. You have secondary arthritis, so if you have an obese person, you will have biomechanical and minor trauma, or if you use overuse of your joint because you work as a tennisman, for instance, or you work in construction, okay, you overuse some of your knee joint or some of your joints, and that will also predispose you to develop what we call a secondary osteoarthritis. The most important cause is the primary osteoarthritis, the one that an individual is genetically predisposed. So OA, or osteoarthritis, is the most common form of arthritis and leading cause of chronic disability in the world. Today, 1 person in 9 will develop osteoarthritis. So normally I start to counting and point you, so you will develop osteoarthritis. Rheumatoid arthritis is 1 in 100, but a lot of more research and molecules have been developed in RA than OA. It's a bit surprising if you think about the prevalence and incidence. But because OA is very difficult to capture the etiopathomechanism, that's why a lot of people in the field of inflammation, in the field of immunity, were interested about RA instead of OA. OA is only diagnosed when clinical symptoms appear. You will see your GPs, and after that, when you have problems with regular drugs, you will see a rheumatologist, and you end up with the hand of an orthopedist at some point. So you seek the advice too late because the disease is a very advanced degenerative process, and obviously because we don't know who will progress, it's very difficult to develop a disease-modifying drug. Very prevalent disease, 750 new cases per year that are diagnosed, so probably about 1 million new people every year. So huge market, almost untouched because there is no disease-modifying drugs. We cannot predict. So we are closer in 2015, about 100 million of people, 25 and up. Okay, these are in the 7 top major market, okay, in Europe. And if you go just in, for instance, in India, they have more than 100 million of people suffering of OA. So why do we need biomarker for osteoarthritis? Obviously, for early diagnosis, better staging the disease so you can adopt lifestyle changement, better drugs to pinpoint what are your needs at that stages. Obviously, it's a very heterogeneous population, so we need to identify those subpopulation, develop predictive marker to assess the risk of disease progression, eventually monitoring response to treatment, and validate those disease modifiers. So 16 years ago, we identified a transcription factor called PTX, that stands for pituitary transcription factor, that is involved during development in pituitary gland development, but also in some craniofacial, like the first branchial arch that will give rise to the mandible, the stomatium that will line up the esophagus and stomachal and intestine, as well as the lower limb. On this immunochemistry picture here, you see a femur at 13.5 embryonic day, where you see a proximal-distal gradient, so stronger at the proximal part of the femurs and going down. And if you do a full inactivation and knockout of PTX1, this is newborn are not viable, and you have obviously severe craniofacial development defect, as well as the lower limb, while the upper limbs are not affected. Interestingly enough, the heterozygous mice are perfectly healthy at birth, but develop all the changes associated with spontaneous osteoarthritis. So in 2007, we studied them, and we published a paper showing that PTX1 was repressed in OA articular chondrocyte. You see a classical RT-PCR, as well as at the protein level, you see the disappearance of PTX1 protein in the articular chondrocyte. So we further investigated what was the mechanism that underlying this repression or disappearance of PTX1 expression. And we identify a region in the distal promoter of PTX1 that encode for a E2F-like promoter region. We use that part to do a DNA pull down, and we couple that with mass spec spectroscopy, and we identify probitin. Probitin is a molecule for almost all seasons. It's a mitochondrial molecules, and that play a role in the crystal morphogenesis and function of mitochondria, but is also associated with different forms of cancer. So breast cancer, prostate cancer, there is an upregulation, and you can see more circulating probitin. Also associated with aging and senescence as well. And this molecule is circulating between the mitochondria and the nucleus, but is rapidly export out of the mitochondria of the nucleus and can go back in the mitochondria, but also through lipid raft can go at the membrane and act as a receptor for different viruses as well. Chikungunya viruses, dengue fever viruses. So a lot of research are going on at that time. So we identified that in osteoarthritis chondrocyte, we see upregulation of aberrant trapping of probitin in the nuclei of articular chondrocyte. This is a classical histochemistry on cartilage section, as well as by deriving the primary articular chondrocyte, you see the accumulation here, while this is a normal expression in the mitochondria. Term 20 is a marker for the mitochondria. Interestingly enough, if you do some cell fractionation, obviously you will see an accumulation of, in the nucleus, fraction of probitin. You still detect a little in controlled cell, and interestingly enough for us, there is no accumulation in rheumatoid arthritis patients. So what we believe is happening is clearly that we are depleting the mitochondria in a way, and it is an aberrant nuclear accumulation in different cell types, so including articular chondrocyte, which form a complex that repress the expression of PTX1. This has been published in arthritis rheumatology. So by depleting the mitochondria, you have less functional mitochondria. So you raise the paradigm that you are probably healthy in your young 20-something, but you start to develop some overweight, and then eventually you be frank obese if you don't pay attention, because your mitochondria are less functional. They are not burning fat as they should, as opposed to secondary osteoarthritis, where you have a morbid obesity due to some other endocrine conditions, and you create some minor trauma. So obviously what we're expecting from a biomarker is that you will be able to detect who will develop OA in a symptomatic population, and among the symptomatic ones, who will progress. You want to look for, identify fast progressor. Unfortunately, all the imaging techniques, you are end up with X-rays, you capture about 30% if you are lucky. With MRI, even with sophisticated now system, about 50% in the best scenario, but you are still what I refer to the irreversible lesion or late stage. If you want to test those patients for any drugs, you will fail. You want to test and detect a subpopulation at risk of rapid progression before that. So that's why we pushed the envelope a little bit, and we looked, because we knew that we have this accumulation, nuclear accumulation protein in osteoblasts and articular chondrocyte, and we look also in the blood cell because those primary OA patients are genetically predisposed. And because PHB1 or protein is expressed everywhere, the same thing should happen in the blood cells. So those are peripheral blood mononuclear cells. You see a normal control. You hardly detect PHB1. And you can refer, we developed a proprietary algorithm so you can determine the number of cells negative versus number of cells of positive for PHB1. But also you can measure by the pixels, you can measure the size and the number of what we call aggregates of PHB1 trapped in the nuclei. So what we are doing with that, this is a real cases. So obviously this is at 52 years females without a family history. You hardly detect PHB1, where you see surgical cases, very advanced, 55 years. So very few cells are negative, and you see a strong accumulation of aggregates amongst each cell. And this is an asymptomatic lady in the middle, 51 years old, without that OA family history, and she will develop scoliosis, not scoliosis, but osteoarthritis, because you see that she's going toward that situation. But we may detect it several years before the first clinical symptoms. Same strategy, so if you don't like imaging system, okay, you can do classical laboratory work with Western blot by fractionation. Again, this is highly specific. It's not associated with aging because we have a very old non-OA patients that are not accumulating PHB1. And obviously, is very specific for osteoarthritis as opposed to mini markers that claims to be specific for OA but are also present in rheumatoid arthritis or lupus and other things that are more inclined to be associated with inflammation. So what we are doing right now is obviously if you do a number of cells positive in this diagram and the number of cluster of aggregate per nucleus, you will see easily that in that subgroup on your right, there's a fast OA progressor. Those are individuals at risk of severe progression, and that's the one that interests the pharma industry. If you can have a stratification of individuals having that, even though that their clinical symptoms are very minor, you will may validate any disease-modifying drug, as opposed to it here. And you might say that why there's healthy also overlap with OA, because aging people, even they claim to be healthy. It's so common OA that you will capture here some of them, and only time will tell you if indeed they will develop OA. Interestingly enough, and as you may know, they have several animal models for osteoarthritis, and we can debate for the whole day about their relevance or not. But we use the STI or T mice because they develop spontaneous OA. And interestingly enough, you see a normal mice, you see a healthy cartilage with a lot of safran and O in the proteoglycan contents, a lot of PTX1 and very few nuclear PHB1, but you see in OA a loss of proteoglycan, a loss of PTX1, and an increased accumulation of PHB1. In the B panel, you see the correlation of the number of positive cells over time, and the little square here represents a C57 black cyst representative index value for the qPCR. So you see that even those strains, which is prone to develop OA, do not accumulate PHB1 as the STI or T, and there is a relative, a nice correlation between the accumulation of nuclear PHB1 in those animals and the repression of PTX1. So now, proving that STRT is a relevant clinical animal model that mimic what is happening in humans, we are right now developing molecules that target the mechanisms that is responsible for the aberrant nuclear accumulation of PHB1. And I won't tell you the real name of the molecule, but as you can see, untreated mice, and those are the beautiful STRT mice, okay? They are real mice, they are not Kobe, they are big, they develop obesity because their mitochondria are not working very well, and they end up on bone. There is no cartilage. If you treat them, we maintain them with prevent the narrowing of the joint space. So in summary, we think that we identify a breakthrough solution for early OA detection before the first symptom. The fact that we use blood cells, okay, we can use many technological platforms, okay, like the Ventana platform that you can do numeric assessment quick, instead to do a different way to do that. So very compatible with existing platforms. Huge global market, okay, a lot of unmet needs, and is not competitive as other in vitro diagnostic assays, such that targeting cancer and infectious disease, at least at this stage, but obviously following the first and second generation of tests, there will be additional competitor on the field. And I hope that I convince you that PHB1 is not only a specific OA biomarker, but also a druggable target. At the end, I would like to acknowledge the contribution of very gifted students. So Cynthia Picard and Martin Pilicelli were the cornerstone of this discovery, and now they are doing postdoctoral training in different institutions. Dr. Jean-François Lavoie, so he fall in love with the business side, so he's in the dark side of the research now, working with Biomomentum, a biotech in Quebec, still on OA. Mr. Sadala Bouanik, who is my research assistant and mouse manager, so without him we won't be here today, as well as Lauriane Bernard, who work on the regulation of PTX1 in different contexts, and my close collaborator, Dr. Patrick Lavigne, who is the orthopedist that provide us the material. Thank you very much.
Minutes before the dog starts barking, okay?
Okay. Let's make sure this kind of works. All right, I'll thank the organizers for having me today. I can see from the agenda most of the discussions here are about the omic molecules, proteins, and genes, but there's another whole scheme of molecules, metabolomics, metabolites, that also can be measured, and the talk today focuses on those. Let's see, how do we focus? Just one quick slide about the company that we've been around for about 12 years. We do measure metabolomics, metabolites, using various different types of CEMS and LCMS-based technologies. We do quantitative analysis and flux analysis as well. So doing the process, and this has probably been talked about yesterday and a little bit this morning as well, there is a whole process that has to go through. So what I'll tell you today is a little story about how we're developing through this process for a marker for multiple depressive disorder. Again, starts with profiling. In this case, we're looking for metabolites using LC and CE-based screening, looking at serum or plasma. Identification, we have a large library, but we also see unknowns. And if those show significance, they need to be identified. There's a validation process where we validate the platform itself, but also validate through larger patient populations. And then there's understanding the biology, why certain metabolites may or may not be increased or decreased in relation to this disease. And then a clinical plan, how that marker might be used in the clinic. We have a pipeline in the company, and what I'll talk about today is the first one here, that's the most advanced on multiple depression diagnosis disease. I'll talk a little bit at the end if I have time about diabetic neuropathy as well. Depression is a major disease in our country. Over 100 million individuals are diagnosed each year with it. There's various treatments for this. There's also misdiagnosis. It's not as easy as getting an MRI scan looking for lesions for multiple sclerosis. It's more difficult sometimes to diagnose and to treat. We have a patent information I'm talking about today, but there is this isn't really working, but there are some patents that we have published on this. For this discovery, we started out looking at plasma from our small cohorts, which I'll describe in a minute. We have SLPs for collecting the blood. Stirring it, it's a liquid extraction, looking at the aqueous layers and using CEMS, TOF-MS to look at for the metabolites. We compared over 500 metabolites that were in all the samples, looking for association with the disease. The method itself is basically you take your serum, you add 2 internal standards prior to extraction. After you extract the lyophilize, you add 3 more internal standards, and we're using about 50 microliters of plasma. The early discovery, as most discovery starts out with, are for small cohorts. In this case, 30. This is really working very well. 31 healthy, or maybe you just read it. 31 healthy, 34 with major depressive disorder, and 7 others I'll describe in a little bit. The diagnosis is done primarily through something called a CES score, where a score is over a certain level, over 17, becomes then, someone can be diagnosed as depressive. So you see the scores in the bottom and the ranges for each study population. So the initial result on the left is a hierarchical clustering or a heat map. These are all relative measurements. From this, we picked out one metabolite which we identified as PEA, phosphoethanolamine. Once we identified this, we went back and devised or made up a quantitative assay. So on the far right, that's let me look at it. This is a concentration on the left and micromolar concentration. And we reevaluated each of the patients once again. On the far left, you have the controls. In the middle is the major depressive disorder, 34 patients, and on the right, adjustment disorder. And there's a significant difference in the median between the controls and the patient target population. So the highlighted there as those outliers are really patients that were at the time, though they were diagnosed with depression out of season. These are seasonal depressed patients. The ROC for the single molecule is very good, just comparing the 34 depressive patients with the non-depression stations. Comparing the PEA levels on the left with the CES score, you get a very good correlation. On the bottom right in the red, you can see the majority of the diagnosed patients. On the far left, under the score of 17 or 18 are the normal population. And in the purple, you have other diagnoses. We went ahead then and looked at another, that was about 70 patients. We looked at another 100, so this is another data set. We get very similar results. So in this data set, well, I'll show on the blue is the healthy to the left. This is look at the HAM score, which is another criteria for depression diagnosis. And so there, 7 is the cutoff. And if you look at on the far bottom right, you see the depressive patients have low PEA scores or levels. Another seasonal depressed patient is marked on the red. Also in this, these cohorts, we had patients that have been diagnosed as having partial remission and full remission, but also we had bipolar patients in here as well. And what I'll mention later, if I get this to really work, you can't really see well, but there's some patients in here that are bipolar. And with the bipolar patients, during the depressive phase, they have low PEA levels. In the manic phase, they had high levels. The next slide shows clearly the correlation with remission. So in the bottom left are the patients that are diagnosed as depressed and with the low PEA scores or PEA levels under 1.5 micromolar. The next is a partial remission, and finally complete remission based on their CES and HAM scores. And that correlates very well with the healthy population and the other population. So we see is that we see a good correlation with the HAM and CES scores. The PEA levels are restored with remission. This gets back to starting to discuss how this might be used in a diagnostic setting. So the suggestion might be that if PEA scores are restored over 1.8 micromolar, that some of these drugs have significant side effects, so perhaps that medication can be reduced when measuring the PEA level. There are patients with higher PEA level that might suggest other diagnoses, and we noticed that in bipolar disease, PEA is low when depressed, high when manic. When we go and develop this, so we realized that CEMS may not be the best method for a clinical lab or a central laboratory. So I already mentioned that we went from the relative data to a qualitative data by going to a triple quad, but to go to more amendable technology, we went to an ion chromatography fluorescent method, which is more amendable to more core laboratories and high throughput testing. At this point, we've looked at over 1,000 patients, and I'll try once again to get this to work. But here we go. So this is our major depression. Over 350 patients have been looked at so far with PEA levels under 1.5. The one just to the left of that, I don't know if this is still working, is I'll just point. These are over 90 patients with partial remission, another cohort of people that are on full remission. And if you go to the far right, the one with the biggest arrow bars are the bipolar patients. And the one next to that is about 300 people with anxiety, which is another common ailment that's often misdiagnosed. And at this point, we're going to even larger studies and looking at a number of different potential effects in terms of exercise, eating, lifestyle, and also other nationalities. This so far has been on a Japanese population. So as we look at the larger studies where ROC continues to improve, the BDI level, you can see greater than 18 has 100% specificity, so anyone with a score over 18 is agreed upon to be diagnosed as being a major depressive disorder. However, it only captures 40% of the population, so it's not very sensitive. Our PEA method less than 1.5, 92% of the patients that have low levels, in fact, are diagnosed as major depressive. And we're picking up 94% of the patients. So at this point, the large-scale validations have started in two clinics in Japan, and that'll probably be another year or more of studies. Oh yeah, much better. At this point, again, looking at a clinical plan, I'm not going to go through this, but this is what will evolve over the next year as to how best to use this measurement in terms of looking at remission in major depressive order, looking at bipolar patients, schizophrenia, and also developing just the correct limits of diagnosis. In terms of the biochemistry, or why PEA might be low in these depressive patients, a couple of observations in looking at the patients that were treated with various drugs, patients with high anxiety being treated with Paxil, Prozac, we find the PEA actually decreases in those treated patients, whereas patients treated with Effexor that have been for depression, the PEA, as you've seen, increases with treatment. And just the cartoon just stating the obvious that depression is a very complicated disease with many neurotransmitters and pathways involved. So how could PEA be involved in those pathways? In one aspect, PEA is a phospholipid metabolism involved in membrane biosynthesis. It's highly available in brain, under young brain, developing brain, under neuroproliferation. It also has structural similarities to neurotransmitters such as GABA. Though it's not active in the GABA binding site, in fact, has activity in GABA A-B site, which is associated with other mental diseases. It also is active in this link to reward pathway with the molecule phosphoenamide, which is this enamide is over here. So it's a link between ethanolamine and arachidonic acid. So this particular molecule, when dephosphorated, becomes active and goes into the receptor of reward receptor pathway. However, if it hydrolyzes, it releases EAP, which can make its way into the periphery. And it's highly abundant in the brain. This is a dated reference, but it was also noted in this study that PEA levels were mostly down in the two areas of the brain associated with Alzheimer's. So the point here is that PEA is associated both with neural activity as well as membrane synthesis. Quick note into another developing biomarker in our pipeline related to diabetic or kidney disease. In this case, we're looking again small cohorts to start out with. All these are diabetics, but here's with no kidney disease here, with very low URAC scores. This is albumin to creatinine ratio, and very high filtration rate, compared to patients that have just the opposite, a lot of kidney disease with very high albumin and low filtration rate, and then a cohort in between. So again, starts out just like before. We do an analysis of serum, looking at relative metabolites, comparing them with various statistical measurements to the clinical measurements. Here we're using a more sophisticated algorithm to look at, because we're getting multiple metabolites to separate out the different cohorts. Each of these dots is a patient. Each dot represents a 5 metabolite panel that separates out the patients with the severe liver disease and those kidney disease and those without. And this is the in-between patients over here, less resolution. And this just shows how you can take the metabolites and you can compare them to each of the different cohorts, as well as compare them to the different measurements of the albumin or the filtration rate. So this is a developing program as it continues. At this point, we have 2 RLCs, one based on 5 metabolites with 2 unknowns, giving a very high separation, and that would still have good separation using unknowns. So at this point, we're identifying these 2 metabolites and identifying or developing quantitative assay or panels for these, and then looking at additional patient populations. So the conclusion is biomarker discovery and validation is a pipeline. It starts with accurate quantitative data, increasing group size and additional controls, requires assay development. It can develop with a single analyte such as PEA or multiple analytes. At this point, then we look at biological and pathway analysis, and as well as developing a clinical plan, which might be an algorithm based on combination of clinical measurements as well as blood metabolites. And that's the end of my talk, and I want to thank Dr. Kawamura he was the lead investigator for the major depressive disorder study. And that's my talk. No, Dad's back.
Alan, you're far too kind. Thank you. Ladies and gentlemen, it's a great pleasure to be invited here, and my thanks to the Omics group for inviting me here. And this morning, I'm going to be talking about what we at Proteome Sciences have been doing, proteomic strategies to overcome tumor resistance to oncology-targeted medicines here. And the title here, and the title here indicates something, that oncology is probably the best area to look for personalized medicines here. And just as a recap, you've probably seen this before, publications upon publications about what personalized medicines is. And typically, this is what it says here. The right medicine, or right patients with the right drug, at the right dose, at the right time. And some people say in the right route as well, and at the right cost. And that cost happens to be the most toxic effects of personalized medicine. That's another story here. So ladies and gentlemen, you bear that in mind. I'm just going to give you the backdrop of why we need to talk about these personalized medicines here. And over here is a roll call of some of the most famous personalized medicines you should know about, starting with Roche's Herceptin all the way down to Erbitux and Xalkori. So some of these drugs here have been around for quite some time. They make a lot of money here. For instance, second generation Herceptin probably makes about £100,000 per use per year. But look at what it is over here. All these personalized medicines are predicated on a diagnostic biomarker here. So for Herceptin, it will be HER2 overexpression. For Zalboref, for melanoma, it will be for the BRAF mutation, the V600, whatever, it could be E. Yeah. And one of the things that we need to really, really focus on here is that these diagnostic biomarkers here are not prevalent in everybody. They are prevalent in only a subset, which is called patient stratification or enrichment here. So for HER2, it typically occurs in about 20% of breast and gastric cancer patients here. It occurs in osteosarcoma, for instance, but not at that frequency, which is why Roche does not intend to do any work on it here. Okay, so 20%, maybe down to about 90% for BRAF mutations for melanoma here. And therein lies how we capture the population to do the clinical trials that we want to do. But we have a problem. When they are working, it doesn't work for everybody. So within this enriched population, 20%, look at this, defined by the overall response rate here, only 15% of breast and gastric cancer patients really do benefit. The other 85% here don't really benefit, even though they're HER2 overexpressors. A big problem here, a big, big problem. If you're the patient, you think, am I the 15% or 85%? We're not sure. Worse than that, we have a problem about durability here. So looking at Herceptin again, this is progression-free survival or mean time to progression. 9 months is all you get, and then you relapse, and then you run out of options. So we have a big, big problem here, and this is highlighted by my next slide here. This is Zalboref here, manufactured by by Roche here. So it took 2 years to develop this drug, and so here's the guy. He takes vemurafenib or Zalboraf. 15 weeks later, look at all the lumps. It's all gone. He looks great, fantastic. 9 weeks later, it relapses, comes out with a vengeance and kills him. What's the point of it? You spend a lot of money, and you end up with this. So the lack of sustained durability of our most precious drugs is costly, not just to the drug industry, to the physician, to our hopes, and to the patient, and to the relatives who are left behind here. It's a huge problem. We can't let this happen. We spend billions trying to get these drugs to work, only for the cancer to come back and hit us. And this is a problem that doesn't just affect oncology, it affects every other disease. It's really serious disease like Alzheimer's disease here. Is this a mistake, or is this this is not a mistake. This is where I come from, and I thought I'll take a picture from London Underground here, because it gives us a very good picture of what our approach is. Say, for instance, you may recognize, if you don't, come to London and I'll bring you around here. This is the central line here. Look at Oxford Circus here. Say, if you actually jump on Oxford Circus, and there's a fast train that goes all the way down through to a location of angiogenesis, which is not good in oncology here. So come over here. So let's imagine this is a signaling pathway here. You jump on this, it goes straight to angiogenesis. And what drug developers try to do is to stop people coming onto this platform here. And what they do is they block it, they inhibit it, and it stops for a while. And after a while, for some reason, it happens again. The station reopens, but maybe not at this station. We think maybe at other stations here, like Bond Street or Tottenham Court Road, and what we try to do is that we try to stop it again. And the worst thing is that you as a passenger become really smart. You think, oh, I can go to Warren Street, I can go to Charing Cross. Ladies and gentlemen, you get the picture here. Just because you stop a signaling pathway doesn't mean that the tumor doesn't understand about the other pathways. It goes haywire. Now, this really is a big problem here. We've been looking at a single canonical pathway here. Okay? And it's all predicated because, in some ways, and I have been guilty of this, because of our obsession about looking at canonical pathways from the genetic viewpoint. So we look at gene mutations here. And this is the profile for non-small cell lung cancer in 2015. This just came out in February, so this is quite fresh. But this picture here, ladies and gentlemen, has not changed in the last 5 years. You look at this pie chart here in 2011, it's exactly the same. And what we find here is that for all the billions of pounds we use in massive parallel sequencing or next-generation sequencing, we don't know what this 40% is, and we will never know because we spent enough. Worse still, when we look at KRAS, we think, gosh, aren't we clever? We find 30% is KRAS. Well, it's not actionable. There are no drugs that hit this. So 75% of your information is non-actionable. It is a big problem with the genetic approach. And let me just show you what we've done here. And this is a typical canonical analysis for BRAF. So you can see RAS, RAF, MEK, ERK, and MYC pathway. So we look here, and typically if you're in pharma development, you go about 1 deep, 2 deep, 3 deep, 4 deep. 4 deep is really, really deep. Now, what we do not know is what lies behind this gray area. Or maybe we choose not to, because it's much easier to go down this route. So what we want to do here is to go to a comprehensive disease pathway analysis. And how we do that is we need to open this up, and what you might find is other alternative or alternate PD markers come up. That's really important here, and what I presented here is just a pathway for ERBB, or the HER2 pathway here. So you can imagine that a lot of things here drive this pathway, but there are a lot of other signaling pathways that are just as important, probably more important. It's a case of it's a fire in your front yard, but there's a bigger fire in the backyard. There's no point putting out the fire in the front because the backyard's still burning and burning your house down. So now I set up the groundwork for what we will try to do here. There are canonical pathways that we're interested in, but there are other things that are not obvious to us. They blindside us, they frustrate our efforts to create efficacious drugs here. So after 20 years in personalized medicine, the question is what next? And what we need to do here, and this is my statement, we need to treat the patient, not the disease label. You can't just say a person has got breast cancer, so, hey, what do we go? Oh, the lady is a little bit beyond childbearing age, so we'll give her a aromatase inhibitor. You can't just do that. We need to really find exactly what's wrong with her, with him. Yeah, and unpacking individual disease complexity is therefore the key to how we proceed further. And the ability to counter this disease resistance and increase durability would therefore add value to the drugs that we already have or maybe are developing. And that is a goal that we try to do. So the what next is here, the how is what we want to do. And at Proteome Sciences, this is what we want to tell you, that our dependence on genetics maybe has peaked. And we want to try something different called proteomics here. We've heard a few things about proteomics, but at Proteome Sciences, we developed a raft of different approaches here. I'm just going to touch on one here. And what we can do here is to comprehensively unpack cancer disease biology in a single shot approach here. You've just got one chance. You've got a biopsy, you've got one chance. The patient is dying day by day, right? So you've got one chance to do this and do this right. Okay? And if you can do that right, you can point to intelligent, not empirical, intelligent, and actionable therapeutic options for this function analysis. We need to know what is driving the tumor rather than what genes it's got. Function analysis is really now very important. And if you can do that, you can anticipate the likely disease routes or resistance routes here, and therefore offer the cancer patient a realistic hope of managing their illness. We're not naive here. The person is dying. We want to give them hope and dignity. It's not about curing it. I'll never say that, but it's about managing it because it's evolving all the time. We want to keep pace with it. We don't want to be lagged behind here. So what we've developed here, amongst other things, is a system called SysQuant, or short for systematic quantification here, which is a unique phosphoproteomic workflow. So we're relying on phosphorylation status here. There are others like glycosylation you may have heard of, but phosphorylation is probably the most important and arguably the most common activation status that you can look for. So we developed this as a comprehensive map of regulatory pathways for any disease. And I've just really wanted to center on oncology here. We've done this for Alzheimer's disease and lots of other diseases, and it's disease naive, if you like, here. So the important point here, ladies and gentlemen, is that we've analyzed samples from tumor and non-tumor samples from the same patients here, because there's great variability in some of these samples, and we really make sure that we're not calling overexpression when actually it's part of the normal range, if you like. So as a treatment, we need to look at the phosphorylation status. And SysQuant combines standard proteomics with the phospholipid enrichment on the latest mass spec machines here. And we use Thermo Fisher's Velos and Fusion, and they're great machines. Thermo Fisher doesn't pay me to say that, but we think they're great, okay? And the visualizations on CAG and GO-term enrichment, and it takes about 4 weeks from samples to data. Now that's really important because in the UK, under the National Health Service NHS guidelines, you need to really make a decision within 62 days. So 4 weeks is well within maybe under half the time that you require here. And it doesn't cost as much, I mean, it sounds like a lot, but you get all the information you need to make a clinical decision. That's really important. That decision will tell you whether a person will live longer or not. So we decided to actually do the work on 2 cohorts from pancreatic cancer. It's not the most common disease. It's the 5th common cause of cancer death, despite being the 10th most common disease here. And about a third of a million people are diagnosed worldwide. In the UK, there's about 8,000 people and that diagnosed with disease, and that figure hasn't changed for the last 5 years or so. So overall, only 3% of people have a 5-year so-called PFS, progression-free survival. No, it's not great here, and the therapeutics hasn't really changed since the 70s here. So until about 2 years ago, if you're a physician, you offer gemcitabine or Gemza, and about a couple of years back, Patrick Soon-Shiong brought up Abraxane, which is paclitaxel, which is attached to albumin, and that works great. And now that's probably the standard of care, in a lot of the drug development situation. So no targeted therapies available here. So quite sad, really, apart from Abraxane, which isn't really targeted. So what we want to say is that if we can identify common and tumor drivers here, we might be able to offer the reasons why we can use certain of the personalized medicine drugs here, so-called drug repurposing. I've deliberately put this figure here so you can't see because they're really quite hard, but I'll summarize it shortly here. two different cohorts. So first cohort, 12 samples, second cohort, 20, so a good clinical validation here. And that's just to say that we've used the fusion in the second cohort, the Velos in the first, and the fusion's been fantastic. It's offered twice as many protein groups and 3 times as many phosphorylation sites in a third of the time. So overall, the cost has come down, and the productivity has gone up. Fantastic, which is why I praise Thermo Fisher's fusion machine here. That's the summary here. 32 cases, total 8,000 protein groups. Now that's really important. You know, if you think that these protein groups represent the products of genes, 25,000 genes, so we're really covering quite a lot here. Yeah, I challenge anybody to actually come quite near to that figure here. So arguably, we've got the most comprehensive map of the human pancreatic cancer ever assembled because of this system here. And we've identified key pathways related to cancer or cancer etiology and activity or proposed activity of how it hits these drug targets here. Now, this is quite an important slide. This is just one of the real data from the PCA plots here. And what we do see here is, if you look at total protein here, the black is tumor and the red are the non-tumor tissues here. You can get a separation here, right? Yeah, arguably, yeah, it's not easy, but you can see clear separation here. But if you look at the phosphorylation sites here, you can get better separation here. So that's for tumor, and that's for non-tumor here. So we now see, and we now say that phosphoprotein is a better disease classifier here based on this. And you can see, you know, there's no doubt what you can distinguish clear blue sky here, right? And what we do here, and these are the analysis, some of the results we've got here from the first 12 samples here, is that when we unpack the data here, we find that actually we want to find out what pathways are regulated or dysregulated. And we find that of all 12 samples here, the tight junction, adherence junction, focal adhesion are very, very consistently dysregulated here. So tight junction. So now we begin to actually understand a lot more about a disease that we have previously no understanding about. Tight junction appears to be really important. It's representing every one of the 12 samples here. And if we look at, if you look at the tight junction here and drill down to some of the about 45 proteins that we selected here, and over here is overexpression, and across this line is underexpression here. If you look at just one of the proteins here, JAM-A, or junction adhesion molecule A here, now that's really kind of like, you know, dysregulated here. And if we drill down further and look over here on the right here, you find that of the 12 samples here, 2 of them maybe have normal levels, but actually 10 of them have got very underexpressed protein here. Now, if you really just want to look down further at the function of JAM-A, you find that actually it's involved in the transition from the epithelial to the mesenchymal function, which suggests that actually the cells are falling apart. They're becoming individual and maybe more motile, and you think when you talk about motility in cancer, you're getting scared because the cells are moving around. You know, you hear words like metastasis is coming about. So now we begin to understand how this is such a dangerous disease here. We are unpacking disease biology here. Now, if I look over here and look at all these pathways here, in many ways that's great. You know, you think, wow, gosh, you know, we can understand a little bit more about disease biology here. But the trouble is that, you know, you can say, Chigi, you know, what are you going to do about this? Trouble is that we have no drugs for tight junction. We don't, you know. So at this moment in time, you could actually say maybe those should be some of your drug targets for the future here. But what else can you do? So another way that we've actually done it is to say, what are some of the proteins that we've seen activated or down-regulated here, and what are some of the drugs, are these the drug targets for these proteins here? So over here we've got the target proteins, you know, SARC, HDAC, all the way down to the REF proteins, the AREF, BREF, CREF, and here are the individual patients here, patients 1 to 12, and don't forget there's a representation of the different locked tumor versus non-tumor, and the red. It's going to bite me in a minute. So I'm rounding now, finishing off, Alan, so calm down. So the red represents overexpression and the blue represents underexpression here. If you look at, say, patient number 1, what you find is that he's overexpressed for the SARC family and also IKK beta here. So as a physician, you might now have the information to say, maybe for patient 1, instead of giving just gemcitabine, we might be able to give dasatinib and denosumab here. And for patient 2, giving dasatinib may not be such a good idea, but maybe denosumab, we maybe want the mTOR inhibitors or AKT inhibitors like everolimus, so that's good. And look at patient 11. This guy is really going to be very challenging. Lots of pathways are activated. We're talking about the whole house on fire here. So what we're going to say is that, look, ladies and gentlemen, as a physician, you're going to have to say, maybe you should tackle this too and see what happens. So constantly monitoring it. This is also a very good slide to see if you are a drug developer here. You can look across and say if you are developing ganitumab here, and maybe if you select these 12 patients, maybe these 2 might respond, the other 10 may not. And the ganitumab was a drug that Amgen did for phase 3 trial, didn't quite work. Maybe if they use this, it might have just helped them. But the thing is that you have to actually struggle to get people who are overexpressing IGF-1 receptor here. This is, again, another way of profiling the disease here with total protein. So generally, if you come in, we say, look, the Sark family, and you see there are lots of proteins here, and typically they are overexpressed. For the RUF family, they're typically underexpressed, maybe the exception of 4 individuals here, and for HER2, the blue is HER1, is overexpressed. So typically, as a kind of like big ground generalized treatment, we might actually say, if you come in with pancreatic cancer, might offer something like dasatinib or maybe lapatinib. Herceptin tends to be quite a big molecule. Big problems in the stroma area, so I wouldn't recommend that, but I would recommend GSK's lapatinib or Tykerb here. So again, a different way of actually saying we're providing information where we can make actionable clinical decisions here. So in summary, we just want to say, CISC1 is a cost-effective and time-appropriate method to actually profile your tumor. It gives a personalized molecular profile here, changes in the phosphorylation status linked with total protein. So together, we can produce actionable treatment options here. And the way that we select drugs is now based on total biology, not organ-centric, like, look, you've got pancreatic cancer, there's no drug, so forget about it, give basic standard of care here. And the ability now to give longitudinal data here can actually offer a consistently good treatment options here. We want to do things better for our patients here, ladies and gentlemen. I think this could actually be something, and I hope that we're going to do something good. Some acknowledgements, and I'm very happy, ladies and gentlemen, to take some questions before the dog bites. Thank you.
Thank you very much, Siggy, for this very
Thank you for that. So a slight change of tactics here, because you've heard a lot of talks about biomarker discovery using various cell lines, etc., and a lot on patient stratification and prognosis. But I'm actually going to present more around the translational gap that you have in early phase clinical trials. So really trying to address the pharmacodynamic issues around biomarkers. So try to address the question, does the drug do what it says it does in a clinical setting? So, so I work at Cancer Research UK. So just to start off the talk with some sobering thoughts, actually, at least within the UK, there are over 300,000 new cases of cancer which are diagnosed every year. And, getting cancer is one of the greatest fears that we have across the globe. Someone in the UK is diagnosed with cancer every 2 minutes, and 1 in 2 people in the UK will actually develop cancer at some point in their life. So globally, it is predicted that the incidence of cancer will double over the next 20 years. So these are stats based on the information that we have within Cancer Research UK. So because the disease is because the disease that it actually kills through metastases, we really need to get some more new treatments. Long gone are the days of chemotherapy, and the scientific landscape is changing to having a bit more targeted therapies. So to address this question, what is Cancer Research UK doing to provide some new solutions? So within Cancer Research UK, I work in the Centre for Drug Development. So we're based in London, and what we really do is sponsor early phase clinical trials, mostly phase 1, phase 2. And we have at any given point about 30 projects. They cover a wide range of agents and tumor types. So we focus on the Cancer Research UK priority areas, which are things like pancreatic, lung, brain, and esophageal. In terms of modalities, we have a wide range, ranging from cell therapy, gene therapy, small molecule antibodies, and imaging agents. One of the key attributes that we do bring to the drug development area is a global partnership. So we have a team which actually works with academia, biotechs, and various industries to try and actually develop some of the more emerging novel concepts that, let's say, industry feels a bit too risky to take on, or the biotechs or academia don't have the actual expertise to do that. So we've taken over 100 compounds into early phase clinical trials, and 6 of them have reached the market, including temozolomide and abiraterone. So what is the focus of CDD? So as I mentioned, really we're trying to work on the late preclinical development stage and the early phase clinical trial bit with sourcing projects from academia, biotech, and pharma. I'm just going to present to you some information on the kind of companies that we work with, the drugs, and the kind of activities that we have. So as you can see, we work with companies like Merck, Astex, MedImmune, AZ, BioInvent, Amgen, GSK, and most of these agents are actually first-in-class molecules. So we are really trying to down prioritize the Me Too type approaches and really work on those novel, exciting compounds. So our sweet spot is around translation from preclinical to first-in-human. As I mentioned, first-in-class agents are highly desirable, and we put a real big emphasis on biomarkers. So what we feel is that, really to address phase 2 attrition later down on the line, if we can't demonstrate that the drug is doing what it's supposed to be doing, so addressing the question, have you got the right dose and the right scheduling, then we feel, there is no point in taking the drug forward any further. So I'm going to present to you a couple of case studies, hopefully to give you some examples on how we actually use pharmacodynamic biomarkers in our trials. The first one is actually a Kylob, which is a CD40 targeting antibody. And as we know, CD40 is expressed on B cells amongst other immune cells. And this study briefly was actually a dose escalation study in 28 patients, and you can see the dose ranges that we tested there. And really the primary endpoint and the aim of this study was actually to look at safety tolerability as you would do in a phase 1 trial, but in addition, PK hacker responses, and more importantly, pharmacodynamic responses. The idea behind that is that, if we can achieve a tolerable safety pharmacodynamically driven dose, then we could actually propose that as our recommended phase 2 dose to take forward. So the graph here, what you see is the B cell number with the 50 milligram and with the 150 milligram, and along the x-axis the time of response. So what I hope you can see is that as you increase the dose here, you see a greater knockdown in the majority of the patients in terms of B cells, and the duration actually lasting for up to 48 days with this antibody. So as we increase the dose to going up to 200 mg as well, we see this consistent pattern. So clearly there was no additional benefit seen beyond the 160 mg per dose as we increase the doses. Correspondingly, what we saw was at the lower doses a hacker response that we lost at the high doses. So here we have a molecule that is well tolerated, and we've managed to show a significant decrease in B cell knockdown, particularly, as I mentioned, at the doses above 160. We also looked at some other exploratory and research biomarkers, looking at the immune cell numbers, cytokine profiling, as you would do in some of these studies, and really to build a more concrete and a confident picture around what this drug is doing in an early phase study. And we believe that the hacker responses were lost at the higher doses, primarily due to the B cells being depleted. So at the end of this study, we were pretty confident that we've got a drug that is safe, that is well tolerated, can modulate a pharmacodynamic response, and there was no beneficial effect from a biological point of view to shift the dose much higher than the doses that we've tested. The second case study is actually on a SARC inhibitor. So this is sarcatidine, an AZ compound. And briefly, this study, in addition to looking at your safety and tolerability, we were, during the dose escalation, we were looking at two key biomarkers. That's serum CTX and the urinary NTX to creatine ratio. These are induced as inhibition of osteoclast activity, and again, the idea here that we wanted to demonstrate was, have you got the right dose and the right scheduling from this phase 1 study. So these kind of studies, really you don't need that many patients, so we can actually address these things with about 30 patients in a typical phase 1 setting. So what you see here is the serum CTX levels, and as you increase the dose from 50 mg to 125 and 170, I hope I can convince you that you see a marked inhibition of the CTX response, which plateaus out around 28 days. A similar pattern being evident for NTX and creatine. So this kind of data really supports in your first in human, first in class type study that you've engaged your target and you can actually measure a biological response. The drug is doing what it's supposed to be doing. We can select the dose and the scheduling based on such data. The third example I'm going to talk to you about is a aurora kinase inhibitor. It's aurora kinase B and C. Specific inhibitor, the GSK compound, and in a phase 1 study, 37 patients in total, but 24 treated at MTD. So in this particular study, we dose escalated up to MTD, but only included the biomarkers in terms of understanding the biology in your expansion arm. So this was done in advanced cancer patients, solid tumors, with a compound being administered 1 hour IV infusion 5 days for every 21 days. So classical phase 1 endpoints, MTD, and looking at PK profile and safety. But we also incorporated a lot of tertiary and exploratory biomarkers, including skin biopsies, tumor biopsies, and circulating markers of cell death like M30 and M65. So with this study, what we did was we looked at the tumors to look at a proof of mechanism marker. This is phosphohistone H3, a well-characterized marker for aurora kinase activity. And what we saw in the 4 patients treated at the dose expansion in a particular solid tumor setting, 3 patients were showing a decrease following dosing in phosphohistone H3. So we were pretty pleased by seeing the results to show that we've given this drug at a dose just above below MTD, and we're actually picking up modulation of our target. So unfortunately, where this kind of opened up a new set of questions, which I'll come on to in a couple of slides later on. So although we were able to show biological activity as demonstrated by a classic marker, we actually found no evidence of clinical activity. Neither did we find any effects on circulating cell death markers like M30, M65. And neither could we find any PD modulation in a surrogate tissue. So we were hoping we could actually use skin biopsies as a surrogate. So it kind of left us with a bit of questions here, saying, because there was no correlation between the PD modulation and the clinical outcome. So going back to one of the previous presentations, have you got the right patient group here? So, it was a dose expansion study in a set patient population. So, maybe we got the right dose and the right scheduling, but have you got the right patient group? But then we question as well, did we actually get the right dose and the right scheduling, because we actually dose escalate based on an MTD approach rather than a biologically effective dose. And it also opened up more questions around the endpoint that we looked at here was an immunohistochemistry-based endpoint, which, as you all know, is more qualitative rather than quantitative. So do we need to incorporate more quantitative endpoints in making these kind of decisions? I'll come on to some of these challenges that we face with early phase oncology trials later on. So within Center for Drug Development, we kind of have like a toolbox for measuring pharmacodynamic responses. So each study is very unique, and we kind of look into this toolbox and see, what is it that we really want to measure in this study. So typically our phase 1 studies, we would have a dose escalation part, and then once we've figured out a dose that we want to take into, we would have a dose expansion arm. The dose expansion arm would be enriched. So this is different from stratification. So we're not looking for a biomarker positive, biomarker negative arm, but we're looking for a patient group that expresses the target and then try to see whether we can actually modulate a particular response. So a range of tumor markers that we would use routinely in our studies. Some of these things have been talked about today and yesterday. And we do try to incorporate a lot of surrogate markers. So typically, the tumor markers we would obtain only in our dose expansion because that's where we would get the hard-to-obtain biopsies. And in the surrogate markers, we would typically incorporate them into our dose escalation because that would be looking at, say, a urine circulating marker or hair follicles. One of the things that we're doing a lot of at the moment is, really expanding the use of ctDNA and CTCs, as well as really branching out in the use of flow cytometry because there are so many number of assays that we could do in terms of demonstrating biological activity using these technologies. So going back to my question around the challenges that we had with the Aurora kinase study, so the whole problem that we have in terms of the real world around the PD modulation is there's little evidence to correlate PD effect with clinical outcomes. So when you go and speak to a clinician and they would always put clinical response rightly at the forefront. So if you do a clinical trial and you see a clinical response, forget the PD. You got a good thing there. So let's get going. But if the problem comes when you don't have a clinical response, as in majority of the phase 1 trials that we do, we are struggling to get a PR. If at best. So then what are you left with? You're left with a safety and a tox study and nothing else. And this day and age, that is simply not good enough. And we really want to show something a bit more. This is kind of where your PD response really becomes critical for taking this compound forward when you don't have a clinical response. I think there was some brief mention about this, around how long, what kind of a PD response do we want to see? What is that magnitude of effect? Somebody talked about that early on. How do you actually define what kind of change is a good enough change when you look at biomarkers? We get people from various industry coming to us and say they want to see a 40% change, 50% change, and when we ask how did you get that number, they just do that. So it's one of those things we really don't understand. And what tissue type do you want to see this PD effect? Are you going to be happy with just the tumor, or do you need tumor and surrogate? But then, if you want to obtain this evidence in the tumor, you really have one shot at goal. It's very limited supply that you have in terms of getting repeatable biopsies. So where do you prioritize? So you might want your tumor in a FFPE material for one assay. In the other assay, you might want it fresh frozen. So how can you get all that information with a really small piece of tumor sample or tumor samples that are difficult to obtain, something like pancreatic? So there is a very little correlation as well between your tumor and your blood-based markers. So these are quite sort of real-life challenges that we face when we're trying to put a data package together in a study report to explain what the drug is doing. And it's also more complicated in the area that we work with because most of our targets, nearly 90%, are first-in-class agents. So these are novel agents that not many of you probably worked on, and you're testing your proof of mechanism assay for the first time. So it's the first time in the clinic with a novel assay, novel target, and you're expecting your biomarker to do a lot. There's a high risk of failure there, and I can talk to you more about those failures when time permits. Well, one of the things that a lot of people don't appreciate is that it really takes a long time to have a good biomarker ready to use in the clinical setting. So I'm talking about using this in a clinical setting in a phase 1 study, and you need to start this in parallel to identifying a new drug, and not when you just identify your lead compound and then you think, okay, let's try and find a biomarker. It takes investment both in time, cost, and resource. And you heard early on about the whole issue around resistance and tumor heterogeneity, and this is something very, apparent in this setting, and trying to overcome this is a big challenge. So a couple of take-home messages. So I strongly believe that biomarkers are key to the success of early phase oncology trial, and this is I'm talking about pharmacodynamic biomarkers and help minimize the phase 2 attrition. So certainly within Center of Drug Development, we really try to make robust decisions based on the end of our phase 1 trials. We are not too keen to pursue a program if it's just only PK, safety, and tox, and we haven't got either a clinical response or a biomarker in there. And I think it's really important to be clear right from the onset, what is it that you want to use from a particular trial design with regard to your marker, and during which part of your study design. So as I said, typically we have an escalation arm and an expansion arm. So expansion arm is often relying on the biopsies, but be realistic about what you want to expect out of that study. So I'm, elaborating. It is challenging to discover, develop, and have a robust clinical assay, particularly for a first-in-class agent. But we strongly believe that without having such pharmacodynamic assays, minimizing any phase 2 attrition will remain a significantly higher hurdle. Thank you for that. Just in time. I'm here partly also to seek help from you guys and see if there's anybody who's got any projects or compounds which are in the late stage preclinical development, which are, say, first-in-class agents, or a technology that you would want to apply into a clinical setting. I would really welcome to hear from you guys, because we really try to work with those folks in academia and in industry or biotech who really got some novel, exciting agents which the charity can support running in a clinical trial. So please come and talk to me. Thank you. Any questions?
Thank you very much, Sid, for this excellent overview.